So, we've heard a lot about asthma already, and we've alluded to sort of these patients that have more difficult to treat asthma, these inflammatory pathways that are involved. And these guidelines, there's actually another guideline that came out in December, the Severe Asthma Pocket Guide from Gina, which is also another helpful guideline just to help us sort of conceptualize how do we identify these patients. But that guideline is really helping ask the question of, what's the difference between a difficult to treat asthmatic versus a severe asthmatic? And then I think building upon that, when you see these patients and someone has truly severe disease, how do you target that disease? What are the pathways we think about, et cetera? And Nick, I'm going to have you lead off with this.
Yeah, I think, Neil, you're bringing a very important point. People confuse often uncontrolled asthma with severe asthma. They're two different things. While you can have controlled severe asthmatics, you also may have uncontrolled severe asthmatics. And some patients with uncontrolled asthma don't have severe asthma. In fact, the most common cause of uncontrolled asthma is poor adherence, misuse of inhaler devices, not dealing with triggers or comorbidities. So that's uncontrolled in general. That's about 40 to 50%. If questionnaire studies in the US show that about 50% of asthmatics, if you give them an ACT score or a questionnaire, they have uncontrolled asthma. They don't have severe asthma. Now, once you treat these, deal with comorbidities, deal with triggers, deal with compliance, deal with use of inhaler devices. Once you've checked this off and the patient requires high-dose inhaled steroid and another controller to control his or her disease, or requires more than 50% of the time in the preceding year oral steroid to control his or her disease, that's by definition severe asthma. That's about 5 to 10%. I mean, it's a small number, but those are the ones, as you all know, cost the system a lot, not only just money-wise, but the morbidities. So severe asthma is a very small group of patients. Once you've done all the checklist, if they still require high dose of inhaled steroid and a controller to control their disease, or need oral steroids more than 50% of the time, that's by definition severe asthma, at least based on the ATS, ERS guidelines for severe asthma.
So once we've identified a patient, then I guess that becomes the next question is, if you've identified this patient that has severe disease, what do you do?
Yeah, I mean, I think that's a hugely important question. I just want to reiterate what Nick said. There's a distinction between the difficult to control asthmatic and the asthmatic that needs a novel biologic therapy. And if you go through that checklist of, are they using their medications, are there comorbidities, are they adherent, have we got the wrong diagnosis, right. Is the environment adverse? If you go through that, the studies show that you're down to somewhere at 10%, perhaps even less than. One study says 4%, one study says 3%, yeah. So it's a small number. And because it's difficult to control, I think we need to break that knee-jerk assumption that therefore they need a biologic. I think that's an important point to make here.
That's the reason the placebo arms in the biologic studies show such a good response. Absolutely. Because patients actually take their medicine.
Exactly right.
And placebo turns out to be pretty good medicine.
Absolutely. Enforcing adherence turns out to be a good medicine, right?